Good day, everyone. Today I'm going to talk about pneumothorax. Pneumothorax occurs when the parietal or visceral pleura is breached and the pleural space is exposed to positive atmospheric pressure. Normally, the pressure in the pleural space is negative or subatmospheric. This negative pressure is required to maintain lung inflation. When either pleura is breached, air enters the pleural space and the lung or a portion of it collapses. There are three types of pneumothorax: simple or spontaneous pneumothorax, traumatic pneumothorax, and tension pneumothorax. Spontaneous pneumothorax or simple pneumothorax occurs when air enters the pleural space through a breach of either the parietal or visceral pleura. Most commonly, this occurs as air enters the pleural space through the rupture of a bleb or bronchopleural fistula. A spontaneous pneumothorax may occur in a apparently healthy person in the absence of trauma due to the rupture of an air-filled bleb or blister on the surface of the lung, allowing air from the airways to enter the pleural cavity. This is called the primary spontaneous pneumothorax. It may be associated with diffuse interstitial lung disease and severe emphysema. The other spontaneous pneumothorax is a secondary spontaneous pneumothorax, which can occur if the person already has a lung disease. Traumatic pneumothorax occurs when air escapes from a laceration in the lungs itself and enters the pleural space or from a wound in the chest wall. It may result from blunt trauma, penetrating chest or abdominal trauma, or diaphragmatic tears. It may occur on invasive procedure through the lungs also. A traumatic pneumothorax resulting from major injury to the chest is often accompanied by hemothorax, collection of blood in the pleural space resulting from torn intercostal vessels, laceration of the great vessels, or laceration of the lungs. A hemopneumothorax is that both blood and air are found in the chest cavity after a major trauma. Open pneumothorax is a form of traumatic pneumothorax that occurs when a wound in the chest wall is large enough to allow air to pass freely in and out of the thoracic cavity with each attempted respiration. Sucking chest wounds happens when there's a rush of air through the wound on the chest wall and it's large enough to produce a sucking sound. Mediastinal flutter or swing occurs when the structure of the mediastinum, the heart, and the great vessels shift towards the uninjured side with each inspiration and in the opposite direction with each expiration. Tension pneumothorax occurs when air is drawn into the pleural space from a lacerated lung or through a small opening or wound in the chest wall. A one-way valve or ball valve mechanism occurs when air is trapped in the chest cavity in each inspiration and cannot be expelled during expiration. In each breath, positive pressure increases within the affected pleural space. This causes the lungs to collapse and the heart, the great vessels, and the trachea to shift towards the unaffected side of the chest, which is called the mediastinal shift. Pulseless electrical activity, you can feel the pulse in taking the heart rate. Pathogenesis of pneumothorax. These are the factors that affect pneumothorax. Familial pneumothorax or has a history in pneumothorax. tall, thin stature of a healthy person, smokers, patients with underlying pulmonary disease. When there's a rupture of blood and relay, this is under spontaneous pneumothorax. Blunt trauma, example, a rib fracture, penetrating chest or abdominal trauma, example is stab wounds or gunshot wounds, or diaphragmatic tears, this is under the traumatic pneumothorax, happens, air enters the pleural space from outside the chest or from the lung itself via mediastinal tissue planes or direct pleural perforation. This would cause ventricular pressure to increase and lung volume to decrease. This would create a positive pressure within the pleural. This would cause the lung to collapse. And when there's lung collapse, there is a decrease in lung compliance and an increase in work breathing, which can be seen that the patient is using his or her accessory muscle during breathing. Also, tachypnea. There is also a decrease of lung expansion and a decrease of oxygen saturation. This is an image of pneumothorax. The signs and symptoms associated with pneumothorax depends on its size and causes. Pain is usually sudden and may be paralytic. Patient will describe this as having pain in the chest. The parietal pleura is rich in sensory nerves, while the visceral and the lung, it lacks sensory nerves. The patient may have only minimal respiratory distress with slight chest discomfort and tachypnea with a small, simple or uncomplicated pneumothorax. If the pneumothorax is large and the lung collapses totally, acute respiratory distress occurs. The patient is anxious, has dyspnea and air hunger, has increased use of the accessory muscle, and may develop central cyanosis from severe hypoxemia. The clinical manifestations is in assessing the chest for any types of pneumothorax. The nurse assesses tracheal alignment, expansion of the chest, breath sounds, and percussion of the chest. Clinical manifestation of simple pneumothorax. The trachea is midline, expansion of the chest is decreased, breath sounds may be diminished, and percussion of the chest may reveal normal sounds or hyperresonance depending on the size of the pneumothorax. Clinical manifestations of tension pneumothorax. The trachea is shifted away from the affected side. Chest expansion may be decreased or fixed in the hyper-expansion state. Breath sounds are diminished or absent, and percussion to the affected side is hyperresonant. The clinical picture is one of air hunger, agitation, increasing hypoxemia, central cyanosis, hypotension, tachycardia, and profuse diaphoresis. The difference of tension and open pneumothorax. The open pneumothorax is in the top and the tension pneumothorax is at the bottom. In open pneumothorax, air enters the chest during inspiration and exits during expiration. A slight shift of the affected lung may occur because of a decrease in pressure as air moves out of the chest. In tension pneumothorax, air enters but cannot leave the chest. As the pressure increases, the heart and great vessels are compressed and the mediastinal structures are shifted towards the opposite side of the chest. The trachea is pushed from its normal midline position towards the opposite side of the chest, and the unaffected lung is compressed. Diagnostic procedures: X-ray, CT scan, and ultrasound is under imaging studies. And the laboratory procedures: the laboratory analysis is generally not indicated. Arterial blood gas analysis determines if the lung produces oxygen and expels carbon dioxide. Treatment: the goal of the treatment is to evacuate the air or blood from the pleural space. Autotransfusion may be needed if an excessive amount of blood enters a chest tube in a relatively short amount of time. It involves taking the patient's own blood that has been drained from the chest, filtering it, then transfusing it back to the vascular system. Pressure dressing is sealing the opening with a gauze impregnated with petroleum. Medical management: antibiotics usually are prescribed to combat infection from contamination, and oxygen therapy. Surgical management: the rule of thumb is that if more than 1,500 ml blood is aspirated initially by thoracentesis, the rule is to open the chest wall surgically. Thoracotomy is a surgical opening into the chest cavity. Chest tube is to expand the lungs and to remove excess fluid and blood from the lungs. Thoracentesis, also to remove air and fluid from the pleural cavity. Nursing management: administer oxygen ordered by the physician. Position patient head over the bed in Fowler's position to promote drainage. Maintain a closed chest drainage system. Monitor a chest tube unit for any kinks and bubbling. And assess for tracheal alignment, expansion of the chest, breath sounds, percussion of the chest, vital signs, and monitor a chest tube system. Nursing diagnosis: acute pain related to positive pressure in the pleural space, ineffective breathing pattern related to respiratory distress, ineffective peripheral tissue perfusion related to severe hypoxemia, anxiety related to difficulty in breathing. Prognosis: a small spontaneous pneumothorax may generally resolve on its own without treatment. A secondary pneumothorax, even when small, associated with underlying disease, is much more serious and has a significant death rate. A secondary pneumothorax requires urgent and immediate treatment. Having one pneumothorax increases the risk of developing the condition again. Most recurrences occur within the first year. Oh, thank you.